So this is inside the third ventricle. You sort of missed the beginning. These are the mammillary bodies, which are important in memory function. This band across here is actually the optic chiasm, which is the crossing over of all the visual information from both eyes. This area here is called the infundibular recess, which is going down towards the pituitary gland. This is the basilar artery sitting right here. And then it's kind of gray. Can you believe that? It's kind of gray behind here, and it's because there's water right behind there. And I just push against the base of the skull with the camera. This is a rigid camera that's not steerable and drivable. I can only kind of push in and out, and then I just break right through the base. And then I'm looking right at the basilar artery there. And I do all of that. This is the clivus, which is part of the skull base. And I put my camera and I can feel it. And I put it right against the bone, and I just push against the bone, so I know that I'm not doing anything too scary. And eventually the floor of the third ventricle opens up, and I enter into this beautiful CSF space. And then when I bring the camera back out, there's that little bit of that tongue of tissue that's sitting there, but this is a much bigger hole than what my partner creates. And I certainly want a big hole so that it stays open and continues to function, and then that's it, I'm done. And it really actually is that fast. This is the port that goes down, the hole that I've gone through the whole brain in order to get down there and create that. So that's my partner hates what I do. So
you have to repeat that procedure.
Pardon me?
Does this grow back and you have to repeat the procedure?
It can grow back, and sometimes you have to go back in. So if I had a patient who failed that 3 years later, then my options would be to go into a shunt-in, which is a permanent diversionary system for spinal fluid, or I can go back to the camera and I can look. And if I look and I see it scarred over, I'll poke it in the hole and not leave a shunt behind.
There's a question up from the door.
Yes?
So what's the advantage of yours and why it makes yours scary, and the advantage of his and why his is scary to you?
So I'll talk about his advantages first. I'm talking about a person who can't defend themselves. The advantage of his is with that flexible camera, you can do more things. So sometimes all we need to do is make a hole and create a pathway for CSF circulation. When that's all that needs to be done, I like to do it my way. If we have to do more, and if I continued that video, more was done. We did a biopsy of a tumor that was behind us on that visualization. So you saw the fourth ventricle, but then we turned our camera almost 180 degrees, and we saw the tumor, and then some little biopsy cups can go down there, and we can take pieces of the tumor. So I use the flexible scope for doing that as well. So that is a huge advantage. And then you saw that very fine little wire that he puts down, and he pokes this tiny little hole, and that's all very pretty and delicate. And then, that's good. And then, there's sarcasm in my voice. And then he takes this balloon, and he passes it, and the balloon's on this very fine little wire too. Puts the fine little wire through the hole, which looks great, very delicate. And then he inflates this great big balloon and rips it back through the hole, which to me scares the hell out of me because it's all lines. You can't see what the heck you're doing. Mine, I'm just ramming this great big camera. But I don't find that I have good tactile feedback from those little wires. I can't feel the floor. I can't feel the base of the skull. I can't feel those things. And so it's all based on vision, which is fine. Mine, it's based on vision and feel, and so I feel a little bit more confident that way. If I know that the space in front of that basilar artery is really small, I'll do it his way because I'm scared to death about ramming this great big camera in front of there, and because you tear a hole in the basilar artery, it's game over. There's no way that patient's going to get off the table, right? They're dead, because they're gonna completely exsanguinate in about 4 minutes, and you just can't stop the bleeding. So I think about that every time I take this great big camera and ram it through the hole, because that's what could happen. But I like the fact that the first thing I see when I make the hole is the basilar artery. first thing I see is the scariest thing in the world. Whereas with his, you're making this great big hole and it's completely blind. So please their own. Yeah?
Does the patient need to be asleep?
Absolutely. Yeah, they need to be very, very still for this. I do mine freehand, so that's the other thing. So if my patient moved a little bit, it probably wouldn't be that big a deal because I have one hand that's on the head. When I take the other hand with the camera and I push it through, and so if the head moves, I can move with the head. My partner does it with a rigid frame that holds onto the camera because it takes an extra set of hands in order to steer the scope. And so if he and I are doing it together, I tell him, can we please not use the rigid frame? And then we've done enough together that we just freehand it together. But if he's on his own, which we are for a lot of our cases, then he'll have it on this rigid frame. I've seen a patient who was apparently anesthetized, asleep, breathing tube in, wake up during this operation and sit up. And then we very calmly yell at the anesthetist to put that back down. So I've seen big tears through the brain in things that are done when you have something that's fixed right here and the patient does this and moves. So I think a lot of what we do is dictated by how scared you are of that thing happening, and so we do something to stay away from it. Yeah?
So that's what you said, Robert. Where do you go into these right? Like where do you go?
Right here. So I make this little hole that's about the size of my index finger, and then just open the leathery covering over the brain, cauterize the surface of the brain, and then just pass. For me, it's just passing a camera in. For my partner, he has to pass a sheet in first, and then the camera goes inside the sheet. Yeah?
So is there damage to the cortex when you do that?
There is. I've made a hole in it, but I've never seen sequelae of that. I've never seen somebody have deficits from that hole. It's a relatively silent area of the brain, and so thankfully we get away with it. Okay. So as far as what types of tumors do I deal with? The majority, or the most common tumor that I deal with is called a medulloblastoma. Slightly more common than this cerebellar astrocytoma, which is again slightly more common than a brainstem tumor. And all three of those are about 2 times or 2.5 times as common as the ependymoma, which is the tumor that this little girl had. And there's a bunch of other tumors that are less common than that. But medulloblastoma being the most common one that we see. About 25% of those kids have permanent problems with their CSF circulation and do require a shunt or a third ventriculostomy like you saw in those pictures after surgery. We try to take the whole tumor out, but we don't have to, which is really nice about this tumor. This tumor is wonderfully radiosensitive, and so when we're operating, we send a piece of the tumor and we send it to the pathologists, and we get an answer about an hour later where they say, well, we think it's this. And that's good enough for me at that moment because it makes a huge difference as to what I need to do for the rest of the day. If he comes back and says, well, we think it's a medulloblastoma, I'm going to say, that's great news. I'm going to do as much as I safely can. And if there's a little bit of tumor that's left behind, I'm not too worried about that because we can radiate the child and they're still going to do very well. These tumors usually come off of the roof of the fourth ventricle, which is a relatively safe place for me to be aggressive. If they come off of the floor, it's much more dangerous. You saw that bit of swelling in the floor of the fourth ventricle in my patient, and she had the eye and swallowing problems and things like that. So the floor of the fourth ventricle is very sensitive. Cerebellar mutism is a very interesting phenomenon, and anywhere from 10%, and depending on how hard you look, maybe even 50% of patients can have some degree of this. And these kids wake up and they have incredible emotional ability. They are crying and inconsolable, and then the very next minute, you've never heard an 8-year-old swear like some of these 8-year-olds can swear. And the parents just are shocked, like, my child never talks like that. And then we all chuckle behind the parents' backs as well. Clearly you talk like that. They learned it somewhere. So a while back, there was a classification that came out. Chang had looked at a number of factors related to survival with medulloblastoma and divided these patients into a standard risk group and a high risk group. And again, the young kids were a high risk group. If we didn't take all the tumor, meaning we left more than 1.5 cubic centimeters, or at the time of presentation the tumor was already spread throughout the brain and spinal cord, they didn't do so well. Specifically, why is the age less than 3 a high-risk patient? Because of radiation. We didn't want to give radiation to the really young kids. And medulloblastomas are very sensitive to radiation. Radiation will kill those cells. So here's a case of a medulloblastoma. And if you can remember from the first slide that I showed you, it looks an awful lot like that ependymoma. And so we will often go into surgery having no clue what we're going to be treating. Okay, and so that answer that I get from the pathologist as to whether they think it's a medulloblastoma versus an ependymoma is really important to me. I either call home and say, yeah, I'll be home for dinner, or call home and say, no, you need to put the kids to bed, I'll be home, I'll see you tomorrow. Because if it's an ependymoma, I need to take it all out. I have to be more aggressive and I have to take those risks. Whereas a medulloblastoma, I can stop early. This is what a medulloblastoma looks like under the microscope, and I will provide a refresher for what the ependymoma looks like, but this is, again, very, very cellular, very high cellular turnover, and medulloblastomas are considered a grade 4 tumor. There's a World Health Organization grading scheme, grade 1 being a relatively benign tumor, grade 4 being a highly malignant tumor. And medulloblastomas are grade 4. They're a highly malignant tumor, but their survival is fantastic. They actually do really quite well. And this 70% 5-year survival is actually pushing, it's probably closer to 80 to 85% 5-year and 70% 10-year survival with a really malignant tumor. They are somewhat chemosensitive, but they're particularly radiosensitive. As we learn more about tumors, we're recognizing that the genetic makeup of that tumor plays a significant role, and we're actually now able to tailor some of our chemotherapy based on what we find on their genetic assessment of the tumor, and knowing that if the tumor has this genetic marker, that this chemotherapeutic agent is going to work, and if they don't have that marker, then this chemotherapeutic agent is better. And that really has made an impact on survival. A cerebellar astrocytoma is the next most common one. Again, most of them are presenting at a fairly young age, and very common in kids and very uncommon in adults. Again, looks kind of like the last one. They're less cellular, so they often have these areas that are full of a cyst. These are some more cysts within the tumor at the back here. And they actually come from the cerebellum as opposed to the fourth ventricle. And the cerebellum, we can take out pretty big chunks of the cerebellum, and the kids do well with that. This is what a cerebellar astrocytoma looks like. You can see this looks much more normal. There's lots of light pink everywhere. The purple are all of the cellular nuclei, and so you can see it's far less cellular, far less active. And all of these red areas, these bright spots, are called Rosenthal fibers. This is a close-up of that. These are Rosenthal fibers. And really, Rosenthal fibers are a reactive process by the brain. Anything that's going on a chronic inflammatory basis causes this reaction in the brain, resulting in these Rosenthal fibers. So these tumors have been there for a long time. They grow really slowly. Patients tolerate them for a long time, which is why they kind of show up at 7 years of age, as opposed to the medulloblastomas and the ependymomas that show up at 3 years of age. Those tumors that are growing very quickly versus the ones that are growing very slowly. The wonderful thing about cerebellar astrocytomas is if I can take it all out, I can in 90% of cases, tell the patient that they're cured of their tumor. It's definitely the best tumor for us to have had in our pediatric population. And so we don't need to give them any radiation therapy, we don't need to give them any chemotherapy, we just watch them. And if they come back, then we'll have a discussion. Do we continue to watch and see if it is going to grow further? Or do we go in and remove that recurrence? Or do we radiate or do this stereotactic radiosurgery for any recurrence later? And we've watched these kids for 20 years. We don't stop at 20 years. We don't have any people who are more than 20 years out yet. We just keep watching them. Brainstem gliomas are a very different group. Unfortunately, they are almost as common as the previous two that I talked to you about. And there's 4 distinct groups. The most common of these 4 groups is this diffuse pontine glioma. Unfortunately, they have a very poor prognosis. Half of those children are dead within a year. Focal gliomas, many of them do not require specific treatment. The reason they come to our attention is because they block off CSF pathways, resulting in hydrocephalus. And in fact, that video of showing you what I do was a 23-year-old lady with a tetraglioma who all I needed to do was treat her hydrocephalus. I didn't need to biopsy the tumor. I don't need to treat the tumor. I just need to watch the tumor. And I've been watching her for the last 3 years, and the tumor hasn't grown. It just caused problems with hydrocephalus, so I treated that, and that's all she needed. These exophytic tumors often do grow, and they are amenable to surgery. But when you think about those tumors, the real important difference is, are they diffuse and are they taking up space over a large volume, or are they very discrete? And so these focal tumors, the tetragliomas, so do a third ventriculostomy, which is what I showed you, and then observe. That's all they need. If they're bigger or they're showing significant enhancement, we give them dye when we do MRIs and CT scans. Those 2 factors suggest that the tumor may be more aggressive and needs to at least be followed more closely, but often those ones will go on to require resection. The dorsally exophytic we remove, and then we talk about whether we should radiate the area or not, and we often don't. We just watch them afterwards. And then these cervicomedullary, which are the other focal tumors, they need a fairly early surgical plan because once they grow and cause problems, those problems are often irreversible. Unfortunately, the common one are these diffuse pontine gliomas. This is the pons here, and you can see that the pons is completely filled by this tumor all the way around. So you can imagine that there's nothing that a surgeon can do for this. We used to biopsy, well, some crazy guys used to operate on these and try and take them out. But that was before I became a surgeon, and those patients were wrecked because all of the information going from the spinal cord to the brain and vice versa was interrupted through that operation. So your patients do. Thank you for it. And then there was a while where they biopsied them, and biopsying it's not easy either. And biopsying it really is not necessary anymore. If I see this picture on an MRI, I know the diagnosis, and I know that they need radiation treatment only, and that they're still not going to do well. So these diffuse tumors, they get 54 gray of radiation, and only 1 in 10, 1 in 5 will live to 2 years from the time of diagnosis. So that's a pretty bad diagnosis to get. I talked about neurofibromatosis earlier. It's one of the genetic syndromes that has an increased rate of tumors. What fascinates me about neurofibromatosis is the fact that they have a significant increase in the number of tumors. Like most patients with neurofibromatosis have a number of tumors, but their tumors are really benign. So it amazes me that you have a genetic syndrome that predisposes you to tumors, but when you have that tumor, you're way better off than if you didn't have NF and you got the same type of tumor. So it's fascinating that their tumors are more benign despite that they have a genetic reason for multiple tumors. So now, ependymoma, this was the tumor that my patient has. Only 10% of the tumors that we see in the posterior fossa, but 30% of the tumors in children less than 3, so again the importance of age. More than half of these present before 5 years of age. And in contrast to the medulloblastoma, which was a WHO grade 4, the majority of what I see are grade 2, which should argue they're much more benign. This grade 1 myxopapillary is a specific type of ependymoma that's right down at the bottom of the spine. Subependymoma, they're basically just warts in the brain, and they don't generally need treatment. These ependymoblastomas are really particularly nasty creatures. And my little girl actually has this anaplastic ependymoma, so it's a pretty bad actor as well. But here's her picture. And again, thinking back to the medulloblastoma, pretty similar looking tumor on the MRI. And so the family always asks us after the MRI, what kind of tumor does my child have? And I always tell them I don't know, that I've got a 1 in 3 chance of being right. It's either a medulloblastoma, it's an astrocytoma, or it's an ependymoma. Even though the statistics tell me that it's likely not an ependymoma, this appearance on the CT scan, to my eye, looks more like ependymoma than astrocytoma. So anyway, I basically tell them I don't know. And I'll know more after surgery. And this is part of the reason why I don't know. This is an ependymoma, and this is a medulloblastoma. And so I put all this faith in the pathologists who take this tiny little piece that I give them as a frozen section during surgery, where they don't make slides as pretty as this on the frozen sections. And I ask them to give me an answer that's going to impact what happens to this child for the next 2 or 8 hours. And if he tells me it's this, it's 8 hours. If he tells me it's this, it's 2 hours. And I just have to say thank you to my pathology colleagues who can tell me the difference between these two on a frozen section as opposed to these beautiful slides here where it's hard enough to tell. So thankfully I have some very good colleagues here that I get to work with. So ependymoma, it's bad. It's much worse than medulloblastoma despite being a lower grade tumor. And it's because primarily of this last issue down here, recurrence. They come back and they come back and they come back, and that's why it's so important that the surgeon is aggressive in taking as much of that tumor out. And more research now is looking at being very, very aggressive with these tumors because because they're not surviving otherwise, right? So these are the kids where you say, I don't need to worry about what happens when they're 18. I need to worry about getting them to 6 or 8 and deal with the consequences later. And while that is generally the way we think about these tumors right now, I'm not necessarily saying that's the right way to think about it. This particular girl has been a real challenge, and you'll see some of the issues that we've gone through in the next few slides. But what are particularly important things in the ependymomas? Well, how good the surgeon is, that's pretty important. If the surgeon isn't good, the outcome's not good. The age of the patient, interestingly, the younger you are, perhaps the better you can do. Is there already evidence that the tumor has metastasized down the spine or up inside the head? What type of ependymoma is it? Is it the grade 2, relatively better, grade 3, relatively worse? And then its location. The spinal ependymomas do really quite well. The ependymomas that are up top in the older patients actually can do well, even though I already told you that younger age is better than older age. There's all this conflicting information depending on how you look at all the data. And then the infratentorial, which are the majority of those that we see, actually do the worst. And then what do we do when the tumor comes back? Do we operate again and again and again? Or do we say enough is enough? So this is my little girl. We knew that she had a bad tumor. We thought we took it all out. And we said that you need to have radiation treatment as well. And so the radiation treatment is done over multiple courses. You can see that she has that little feeding tube in her nose right there still. She's awake, but given some sedation for this. She doesn't have a breathing tube in. She's not on a ventilator. She has this mask that's created and formed specifically to her. And then she gets put into this machine that's taking multiple pictures, registration across the mask, and recognition of where the tumor is relative to the mask. And then the radiation is delivered by that same machine at the same time. So it's taking a picture, and shooting radiation, taking a picture, shooting radiation, taking a picture, and doing this. And she goes in, and there's multiple different ways of delivering the radiation treatment. So how does radiation treatment work in killing these tumor cells? Well, it breaks nuclear DNA. It breaks nuclear DNA in all of your healthy tissues, but it also breaks it in all of the tumor cells. And the reason we can use radiation or chemotherapy, the philosophy is the same, and that is tumor cells are growing really fast, and so they're going to be more susceptible to anything that damages DNA. And so that's why we have these mechanisms. There's also potentially some impact on different aspects of the cell cycle and programmed cell death, which is what apoptosis is, with radiation treatment. And as I said, it utilizes that biological activity of tumor cells being very, very active and constantly wanting to divide and grow and divide and grow and divide and grow. And so all of that requires ongoing splitting of the DNA, and through that there is more impact on the tumor cells than there is on the normal tissue. Sometimes radiation treatment is all you need to do. We have some tumors that I have to do a biopsy. That first video that my partner did, he biopsied the tumor, confirmed it was a type that we're not talking about today, and all that patient needed was radiation treatment in order to kill those tumor cells. So that would be definitive radiation therapy. That's the only treatment. Palliative, trying to alleviate some of the symptoms with no real goal of killing the tumor and long-term survival, but just to make the quality of life better for whatever time is left. And then adjuvant chemotherapy, or adjuvant radiation therapy, is radiation therapy that's part of the overall spectrum of treatment, which includes chemotherapy and surgery. We can deliver radiation with either photons, which is electrons, or photons or protons, and so photons are just X-rays, right? And they're given with numerous different ways. This conventional external beam radiotherapy, they used to be these two-dimensional systems that would deliver radiotherapy, and when a photon goes through, if this is my tumor, the photons are going through, everything's being exposed to radiation, the tumor's being exposed to radiation, and everything past it is continuing to be exposed to radiation. And so then as the radiation oncologists got smarter and smarter, we realized that if we could rotate this system and give a little blast here, and a little blast here, and a little blast here, and a little blast here, that the amount of radiation experienced by all this normal tissue was very small, but the amount that converged on the tumor was high. And now the engineers and the physicists are able to create these beautiful tumor maps for even tiny fingers and tongues of tumor, and you can basically draw out these tumors and create the radiation, the beam radiation, to rotate in such a way that it is very specific in the way the tumor gets a maximal dose of radiation, and the healthy tissues around it is relatively spared. Stereotactic radiosurgery, what this is a very smart system that gives radiation dose from 170 degrees around the patient, but basically from all fields in a very high dose once. And so that's where the idea of radiosurgery comes from. It's a killing dose of radiation at one time. Stereotactic radiotherapy, as opposed to radiosurgery, is what we have in Edmonton. We don't have a gamma knife yet. We deliver tomotherapy primarily at the Cross Cancer Institute. And the idea behind radiotherapy is that you deliver this radiation dose, the healthy tissues are exposed to some of that radiation, the tumor is exposed to more, and then you let all the tissues heal a little bit. And then you come back the next day and you get more. You come back the next day and you get more, and you do it every day or 5 days a week for 5 to 7 weeks. And the healthy tissues have more time to recover because they've been exposed to less radiation with each dose, and the tumor has less ability to recover over that time. So the interesting thing is you become biased towards what you have. So the group here loves radiotherapy. The group in Winnipeg swears by radiosurgery because they have a gamma knife. The interesting thing is my partner, who I showed you that video, is trying to really create a legacy here in Edmonton, and he'll probably succeed because he's that kind of a guy. And we're probably going to have this and this and this in the next 10 years. There's no proton facility in Canada. There are half a dozen in the States, and the interesting thing with protons is they go in and they're not dropping off much energy, and you basically detonate the proton right on the tumor, and then there's no radiation past that. And you set that in the program that you have the proton deliver its energy to the tumor, and there's very little spread of radiation around that, so it's very good for delivering radiation to very delicate areas. So the biggest place where it's used in the world right now is for prostate care, because apparently men don't want to have the nerves to their penis when they're having their prostate treated. There's probably a huge role for protons in brain tumors. And in fact, we're moving towards the process now where all of our patients who are diagnosed with medulloblastomas are being sent to the States to have protons because we believe in it. And if we spend enough millions of dollars sending patients elsewhere, then the government will see the rationale for spending millions of dollars to build a proton facility in Canada. So that's kind of where we're at. So fractionation is what you do with radiotherapy. You give small amounts of radiation each day, 5 days a week, for 5 to 7 weeks. And so when we look at the literature of radiation doses, you see that a lot of people get 45 gray, 54 gray, or 63 gray, and it's very specific, related to how many weeks of therapy they get. Basically 9 gray per week for 5 to 7 weeks. You can even go a step further and you can do hyperfractionation, which means you have 2 or 3 doses a day. And so the dose that you give each time is less, but you give the same total dose per day. The advantage of hyperfractionation is you're going to have more cells at different stages of the cell cycle, and you're going to hit them at those sensitive stages of the cell cycle. So hyperfractionation is a mode of radiation delivery that's increasing because it has a greater killing capacity and preserving the normal tissues, because the normal tissues aren't dividing quickly. They're all kind of in that same phase of their cell cycle, so you're not getting that same killing benefit with hyperfractionation as you are to the tumor cells that are rapidly dividing and changing the phase of their cell cycle. You have to deal with the long-term consequences of radiation. Short-term, patients are very fatigued, a lot of nausea and vomiting. Radiation is going to affect all of the tissues that are turning over rapidly, so that's primarily the tumor cells, but also the cells in your gut, in your oral mucosa. And so there's a significant loss of taste because of some sloughing of cells within the mouth. The parotid gland is often affected, and so their saliva becomes very thick, and the pH drops, and so they start getting lots of cavities. So there's lots of impact to the mouth and to the gut with their nausea and vomiting. And again, and the hair follicles, which are also turning over rapidly, so they often have hair loss, and you can see exactly where the radiation was delivered, because they have this patch of baldness right around here, and you know that was where the beams of radiation hit the skin, versus the ones where they're getting the radiation from all sides, they'll be bald all over, so you can tell what kind of a treatment plan they have based on their hair loss. Chronic effects. Radiation damages all of the microvasculature, and also probably depletes some of the stem cells. We have lots of stem cells within the brain that we don't understand very well, but they're there and they have an impact. And so long term, unfortunately, you get dumb with radiation treatment. There's significant drops in IQ. You also get endocrine dysfunction if the radiation goes through the hypothalamus or the pituitary gland. And so a lot of these patients are on lifelong hormone replacement. Damage to the lymphatics, causing constriction, and so they become very swollen because they don't have proper drainage of their lymph. Wounds don't heal well. Again, a loss of salivation. This Lermite syndrome is when they flex their neck like this, they get these shock-like sensations that go down their spine, and it's due to this usually reversible inflammation of their spinal cord. Hearing loss is not uncommon, particularly in patients who've also received this chemotherapeutic agent, cisplatin. And then if they try to avoid the eyes with the radiation planning, so the radiation planning will sort of go from here up and from here down, sparing the eyes because of cataracts and dry eyes can lead to scleroderma and visual loss. So this is my little girl. You can see that she's got the feeding tube out now. She's had a radiation treatment. She's lost all of her hair, and she was looking pretty darn great. And unfortunately, a year and a half after treatment, she has no tumor where we operated, but she's now got some tumor up here in the ventricle. And so then we had a long talk about what we do for this, and we decided we should go after it, take it out. And her surgery was much more difficult, which is why I give you a bad-looking picture. She was really hurt from this operation, and she was sick for a number of weeks, recovering, and the tumor was, again, very, very cellular. This is some normal tissue that we had to go through in order to take the tumor. So here's your comparison of normal tissue versus very high cellularity of the tumor. And then, so that was in August last year, and 4 or 5 months later, she's had some recurrence in the original tumor bed back here. And so there was and the tumors that we had tried to take out up here, she had more radiation, specifically for these tumors, and they didn't grow after the combination of surgery plus radiation, so they were stable. And we had a lot of arguments, actually, as to what to do about this tumor here and this tumor. There's actually 2 separate tumors. What we should do about it. And some people thought we should do nothing, and that it was time to turn our focus to the quality of life that she had left, and she's going to die from this. And I kind of got emotionally attached to this girl, and I wasn't willing to say no. So I said, no, we're going to operate. We're going to take this out. These 1, 2, we're going to take these 2 out. And so this was her a week after surgery. She did way better with that 3rd operation. This is the scar. Didn't heal or wasn't healing as well as it did the first time because she's had radiation. You can see she's getting some hair growth back. You know, that surgery was only about 6 weeks ago. She was back at school actually a week after surgery, which made me feel really good. That at least, even if I'm going to fail in treating her cancer, and the cancer's going to come back and she's going to die from it, at least I didn't ruin her quality of life. And I've given her a fighting chance to live a little longer from taking her tumor. Because the worst thing, and the reason others were arguing against me, was what if I go in, operate, and I just wreck her? And then the 4 months that she has left to live, she's living in the hospital, she's not living her life. And so that was a big concern. So her being up, walking, and active within 3 days, and back at school a week later was really great. I didn't ruin the quality of life that she has left. She's already had radiation twice. She's had double the normal dose of radiation, and so felt she couldn't have any more for a reason that I didn't talk about earlier, and that is if you give too much radiation, that damage to the microvasculature ultimately leads to necrosis. And if you cause necrosis in the brainstem, they just stop breathing. So she can't have any more radiation. And so we're talking about chemotherapy. And again, it's dealing with all of these issues in these really young kids. How aggressive are you? And what role does chemotherapy play? Chemotherapy at present doesn't have a great role in ependymoma, but we're continuing to try, and we're continuing to try new compounds and new combinations of compounds. But these are the different classes of chemotherapeutic agents in general. We have these alkylating agents, which leads to cross-linking of DNA and therefore inhibition of DNA synthesis. So this doesn't actually kill cells, but it stops them from replicating and growing. The anti-metabolites do the same. It just slows down growth of tumor. Plant alkaloids arrest mitotic activity, again preventing cell division and growth. Antibiotics can block synthesis of DNA and RNA. And then hormones are important in treatment of tumors that are very receptive to estrogen usually, and that can become problematic, particularly during pregnancy. So most chemotherapy actually just stops the cells from growing, stops the tumors from growing, and then relies on the body's own mop-up mechanisms, apoptosis, to have some death of the cells. So side effects, again, nausea, vomiting, and hair loss, significant bone marrow suppression, and then some of the chemotherapeutic agents can cause a lot of toxicity to the nerves. And again, I told you earlier about the impact of cisplatin on hearing loss. So with 1 minute to spare, I'm not going to talk about any adult brain tumors today, so they're in the handout so you can ignore it. And I'm happy to take any questions you guys have. Yeah.
How do you go about defining
So the question was, how do I become what I am? I was a really good student when I was your age, and then I was a really bad medical student, which is actually true. So I did kinesiology. I'm very proud of what I did in kinesiology, so I tend to be very derogatory to other programs. But so I did a lot of neuroscience in my kinesiology. Did some research. Decided I wanted to take care of people with spinal cord injuries. Decided I could either be a researcher, which I didn't want to do, or become a neurosurgeon. Said, okay, well, I can be a neurosurgeon. Then I had to go to medical school, so I sat in the back of the class, and everybody up there was actually awake, which was impressive, because if I was sitting back there, I would have been out. Somehow got through medical school, and then moved here to become a neurosurgeon. So it was 8 years more after medical school to get to where I am. Time.
So you just kind of started out as like a normal, like a regular surgeon?
So no, you go straight into neurosurgery. So you finish medical school, and then you enter your residency, and for me it was neurosurgery. And that's a 6 or 7 year program, but I did a master's while I was doing that, so I made it 7 instead of 6. And then I had